Good afternoon. My name is Albert Iwasaki, and I'm Group Head of Social Infrastructure Project Delivery of Plenary Americas. And I'd like to thank you all for joining us for our panel today on Canada's hospitals and innovating after COVID-19. I'd like to start first by briefly introducing our esteemed panel, starting with Anne Ford of the William Osler Health System.
Thanks, Albert, and good afternoon, everyone. I'm Anne Ford, Executive Vice President of Strategy and Corporate Services at William Osler Health System, located in Brampton, Ontario, northwest portion of the GTA. Within my portfolio, I have our redevelopment activities along with our facilities operations and strategy.
Thanks, Anne. Next, we have Glen Landry from Plan Group.
Good afternoon, everyone. My name is Glen Landry. I'm the Executive Vice President at Plan Group, and my focus has really been on technology, innovation, and R&D for Canada and part of our global R&D programs.
Great, thanks, Glenn. And last but not least, Jean-Michel Read from Johnson Controls.
Thanks, Albert, and good afternoon as well. So I've spent the last 25 years in managing facilities in healthcare, higher education, commercial, institutional, and I essentially the last, I guess, 14 years or so, I was trying to count the numbers, exclusively in the P3 field. So I've got experience in managing teams, operational teams within the P3 contracts across Canada and the US, on through ostensibly the bid into design and service phase. And my portfolio includes a mix of eclectic mix of courthouses and schools, detention centers, and some civil projects, and obviously some hospitals as well.
That's great. Thank you, Jean-Mi, and thank you to our panel for joining us today. Turning our head to our agenda for today, we've developed some questions to lead our panelists through a discussion. In addition, the audience is able to ask questions through the conference website, so if you have them, please send them through and we'll make our best efforts to address them. Starting with COVID impacts and response, as a P3 developer, Plenary invests in and manages a large number of projects in various asset classes, and they were all impacted by COVID in some way, shape, or form. Though specifically in healthcare, these facilities have faced the brunt of the issue. As the pandemic arose, what impacts did you all see in the facilities and projects that you're running and delivering? Maybe, Anne, you could start us off.
Sure, and thank you. So for a little bit of context, William Osler Health System actually has three different P3 contracts at our three of our facilities, along with some owned and operated facilities management in an older tower. But I think there's a couple things I want to talk about. First of all, I think we can all agree that this pandemic has changed the way we personally and professionally view and work within healthcare facilities. It's also emphasized the importance of infection control and how the built space can either support and or hinder the management of disease outbreaks and pandemics. But I'd like to talk about three specific themes today, if I may, those being physical space and the use of space, the impact to building systems, and then finally, safety would be the third one. So when I talk about physical space, I'm defining that of just about every space you can find in a facility, hospital facilities, things such as patient care units, waiting rooms, public entrances, exits, staff spaces, parking, storage, etc. So the three things I want to really talk about within physical space are physical distancing. The pandemic has shown us, and the way that this virus works was that, a space of about 6 feet between individuals helped with infection control. So the way that some of the impacts that we had within our facilities was, how do we segregate patients? And it wasn't necessarily just in an inpatient unit, but also in an outpatient clinic, et cetera. And how do we segregate some of our staff? Because you can imagine in a cafeteria, we have staff going down, but they're supposed to stay 6 feet apart. So how do we segregate some of our staff in some of the areas? Additionally, how do we use spaces for alternative purposes? We had screening We had lineups that went out the door of folks waiting to get into the hospital, both staff and patients, to be screened for their infectious state. We built assessment centers. We built vaccination centers. We needed administrative spaces to do that. And we also used some clinical spaces for our cold and flu clinics and our assessment centers. And then sometimes we forget about the site, but also like parking spaces. Some of our colleagues in other hospitals use their parking lots to build tents or alternative spaces for patient care. At William Osler, we did not do that, but we certainly did use interesting spaces for a number of our clinical needs. And that brings about a capacity issue when we talk about the physical space. We looked at how do you purposefully locate soft spaces to support a quick conversion of space. So when we talk about a vaccination center, we converted our large auditorium at Brampton Civic into a vaccination center. How do you look at shelled units over time and other areas? And when I say shelled, are they actually fit out to a certain point, or are they really shelled? And what can you use them? Again, some of our colleagues in hospital systems had shelled space, and they actually built out new units. Circulation became a very big topic for us. And it wasn't necessarily just inside the building, but also outside. Again, how do you queue up staff as they're coming in out of the parking garage? It's cold. How do you maintain some safety there? All of our entrances, which entrances do you close? Which ones do you open? Where does the public come in? How does clinical flow work? If staff have to leave their units to go down to the cafeteria, typically in our hospital, you have service elevators, but you also have public and service elevators. So we had to look at that, and really even elevator sizes, because we're down to where you can put 2 people in a passenger elevator. At the time when we didn't have a lot of visitors, that worked. Now that things are coming back forward and coming open again, I would suggest that maybe our passenger elevators, not the service, but our passenger elevators could potentially be bigger. It would have been nice because now we can get more people into those spaces. The second area theme I really wanted to talk about was building systems and the impact on the building systems because of the COVID. One item that came up is around our oxygen storage and oxygen compressors. A new form, I guess it's not really new, but rather than putting someone on mechanical ventilation, we started to use airvo units. And lo and behold, we quickly understood that using an airvo unit delivers 2 to 4 times the amount of oxygen, which affects the flow and demands of the overall performance of the oxygen system, which ultimately can limit the number of O2 units and delivery devices you can use on any one unit. Luckily, we came through that okay. We had enough storage, we had enough pressure, but it was something that no one, I think, would have thought about. We talked a lot about zone pressures between different units and requirements to convert spaces, and do we have enough monitoring of certain spaces? How do we build in some HVAC filtering, directional airflows, air exchanges to make sure that we can do aerosol generating procedures in a space that may not have been purposely built for that. That became something that we really talked a lot about. And then finally, the third thing was around safety. And when I talk about safety, it really is staff, it's patients, it's visitors, it's anyone who's in the hospital, a lot of our contractors. We consider our P3 partners as, staff and lots of implications and impacts to the facilities around that. PPE requirements alone. Theoretically, we're all supposed to handle 3 months of PPE. Well, we had lots coming in the door. We didn't have storage for it. So we brought in some lockers and stored some of our PPE out in the patient hall or in the parking lots. Circulation routes. The one thing on the units that our facilities weren't quite prepared for is all the donning and doffing of PPE. You have to do it in the hallway. You can't do it in a patient room. Where do nurses, doctors, et cetera, do that? And you see some pictures of in like a doctor's lounge, you see up on the wall, lots of nails holding up everyone's face shields. Didn't think about how much storage you need to store a face shield. I talked a little bit about the segregation and the isolation areas and the increased needs. We put in a lot of physical barriers because we don't have 100% private rooms in our facilities. We actually brought in partitions, worked with a number of contractors to work through to where we could segregate patients within a patient room. Cleaning, another big thing as we try to prevent infections. Materials use. You can see, and our hospitals aren't the only ones where we've actually had a lot of material degrading because of all of the wipes and things that we had to use. Did we have enough hand washing sinks? I would suggest we did, but again, as you've got people hand washing their hands multiple times, that might be something to look at. And then finally around safety, and I think it's really come to the forefront around a lot of mental health and issues going forward. We did not have enough respite spaces for our staff. A lot of staff lounges that were built in before were converted to other spaces. Staff need a place to go, relax, take off their masks. They may be physically separated, but it's something to think about certainly, and it impacted our staff as we've gone through the last 18 months. So I'll stop there, Albert.
That's great. Thanks, Anne. And I think you could probably go on a lot longer just because you were really impacted firsthand, you know, not just on the Peel Hospital that we have with you, but all the hospitals across your system. I guess getting another perspective on it, Jean-Mi, you know, as an operator who works in a number of healthcare facilities who, you know, went through COVID, what were you seeing?
Thanks, Albert. Yeah, I mean, a lot of what Anne says resonates with me, and you know, I won't repeat those things, but I guess one of the counterintuitive issues that we faced actually was, particularly during the early stages when you know, there weren't a lot of people in the hospital, and perhaps some areas were underutilized or even shut down for a period of time. You might expect as a service provider that, hey, that's great, you don't have to look after that area, but it actually ended up imposing you know, more work on our staff because, you know, if toilets weren't being flushed, valves weren't being turned, you know, sliding doors weren't being cycled, and if you don't do the kind of things that is expected to be done with those, then they tend to seize up. They don't work properly, and then they create more work for us later on. And of course, we had the same, you know, supply chain issues and issues with subcontractors and so on, and you know, we did everything we could to help with you know, physical barriers, and you know, I know a lot of our staff went out and had signs printed up. I think we had hand drawn signs for a while. You know, anything to do to help, but certainly, you know, the looking after the areas that weren't being occupied, in combination with mitigating strategies like split shifts. So we would split our entire facilities technician shifts in half so that, you know, one got exposed, they wouldn't expose the other half, and that would we'd be able to continue our services. So we were faced with kind of more work with less staff, but somehow we all made it work.
That's great. Thanks, Jean-Mi. And Glen, I guess you with Plan Group, you guys were finishing a number of healthcare facilities construction-wise across the country. What were you experiencing?
Well, I would say the challenge we have is obviously these are fixed fee and very defined timelines for turning over hospitals. Our challenges were similar to what Anne and Jean-Michel said. So we had a lot of productivity impacts related to the restrictions and the changes by province to province, which was a challenge to keep track of. Material costs were kind of out of control, and I think everybody's seen that, between 100 and 300%. Manufacturing delays were really an unfortunate part of all this, which was sometimes upwards of 8 to 10 months we've been seeing. And shipping costs, which we didn't anticipate, of, you know, over 500%. So I mean, I think you're hearing everybody from operating to, you know, physically, clinically operating and building. There was a lot of impacts on a lot of sides. But I think the positive note, because I want to leave it on a positive, is we have been able to get through it, and we have still been able to successfully turn over you know, world-class smart hospitals as part of our contracts. So I'm quite excited about that.
Yeah, for sure. No, we saw some of the material shortages firsthand as well. One of the hospitals we were finishing together with Plan Group and JCI was the Cordalucci Vaughan Hospital, which opened initially as a COVID-only hospital, but it was in the peak of COVID, and at certain points had to get letters from ministers or very senior government officials just to get material across the border.
Yeah.
Mm-hmm.
So I have a couple other questions related to this, but I think we'll save it for the end of the session, just keeping the time in mind here. So just kind of switching gears to chat about P3 facilities and kind of the contract as well. P3 facilities, they're typically contracted with performance requirements, but with the changing needs of COVID and potentially varying performance requirements, how are these facilities able to address these changes through the PSOS development, design, construction, and operations and maintenance phases? And in addition, was the P3 contract used on your projects to address and adapt to the changing requirements during COVID? Maybe we can start with Jean-Mi on this one.
Sure, thanks, Albert. Yeah, I mean, the contract on the operations side clearly contemplates mechanisms for adapting, I'll call it, right, through innovations, variations, change in law, and other relief mechanisms. And so, some of them I've mentioned before, building physical barriers and so on. We installed a lot of plexiglass. I remember that. And surprisingly, the price of plexiglass went up incredibly high as well during the period. We had changes in use. In some cases where the design permitted, there were changes from to change pressure zones within the hospital, swap to 100% outside air. In some cases, those were used as they were initially. In other cases, despite our best efforts in trying to plan for such an event, it just didn't work out, right? So we had to change. I remember one hospital we had set up through the design several disparate areas to be able to change to those requirements, and the hospital, due to staffing needs and the way that they were driving the work, preferred a larger contiguous zone rather than a bunch of disparate ones. But nonetheless, we had some of that preparation within the design to allow us to do that. We just had to adapt again. But those are just the mechanisms. Really, the preparedness and adaptation started, from my perspective, during the teaming phase, very early on in the project, right? And really, the driver for that is the framework of risk transfer. So that, when we get together as a consortia at the very outset, we're incentivized, to perform the right behavior. And for the service provider, that's really the appropriate mix of maintenance, redundancy, life cycle, all in an effort to reduce impact to the hospital when these unexpected situations arise, or for that matter, when during normal operations. And it's the value of doing it that early is we can sit down with our design builders, our design team, Plan Electric, all the big players, and we can chart out which types of equipment that we're going to be putting in, and based on that can inform the types of redundancy that we need to have in place, or the maintenance program, or the life cycle. And there's that right balance that's struck at that stage, and I think that's really the only efficient time that we could do that. But of course, we had that flexibility in design. I spoke to that a little bit earlier, but I think we can do the best we can to do that. And it's great to put the basics in, but I think the expectation is that nothing we think of years ahead of time is going to work exactly for us. We need to be prepared to adapt that to fit our own, fit that particular circumstance. It's going to be dynamic. And that's where I guess the benefit of Johnson Controls having a lot of their own kit within these facilities, like the BMS, the chillers, and other pieces of equipment. Us as an OEM, we were able to bring that expertise, right? The the ability to innovate very quickly, and having that team of professionals, which included our corporate our branches, but also dedicated subject matter experts and engineers that continue on during the operating phase, really helped us out. Dealing with that unexpected. But if I have to say the biggest impact that is specific to this model was really the deep relationships and partnership that we create during the transition, right? And I call that, for the operator, ostensibly, 12 to 18 months before substantial completion. And so that's where we're sitting down with the hospital. It's a bit of a struggle, right? We're trying to take people's attention off of the shiny new building that's going to happen at substantial completion and say, don't forget about us, right? We're here for another 30 years, and although the contract does explain or does give us our obligations, it doesn't necessarily tell us how we're going to work together to ensure that we're going to execute our obligations in a way that is best aligned with the hospital and helps the hospital during the operation. So that's a process anywhere between 12 and 18 months where we're sitting down with the hospital, we're building those deep relationships, we're meeting with the clinical managers and other managers within the hospital, we're getting to know IPAC, so that when something like this does happen, it allows more flexibility and efficiency, right? We've already got all the groundwork laid out. We know how to communicate with each other, and that's really born out of that process. It is a challenge to shift that attention away from the construction and the shiny new building, but it's essential to do that at the outset. And then some of the other things that I had said resonated with me as well. Like during that period, we dealt with harsh cleaners and disinfectants. I think you mentioned the wipes, or the disposable wipes, as I'll call them. They aren't really disposable. And again, that relationship that we had developed during transition allowed us to deal with those things pretty efficiently and provide input and mitigate any risks associated with them.
That's great. Thanks, Jean-Mi. I guess, Anne, as someone who has developed 3 different P3 facilities, as well as other hospitals prior to COVID, or prior to the P3s, what are your thoughts on this?
Yeah, I agree with Jean-Mi, and my suggestion would be that the partnership starts when the contract's signed, and that we need to have the operators and hospital engineers, et cetera, at the table even before the transition period. The 3 projects we have right now that are on the books and operating are DBFMs. We are in the process of planning a DBF project. We need to look at how that contract is going to come to be, to make sure that, because we won't have the M on it, to make sure that everyone's aligned, even during design, that we are putting in the right equipment, that we are all on the same page around cost and value. That's where I think the rubber's going to hit the road around innovation and others, because now the issue is going to be a 30-year plus on the hospital. So Jean-Mi is absolutely right. The partnerships is so key on this, and we have worked very hard here at Osler to try to even include our clinical teams even before we get to that transition period of really understanding what's happening in their units and trying to help them articulate what it is that they're trying to achieve. Because that's what starts at output spec. What are you really trying to achieve? What kind of outcomes are we really looking for from a clinical model of care, et cetera? And then we're looking to our experts, our engineers, our architects to kind of make that happen. And so when we transition the building over, there's always hiccups. We know that, but they're not major hiccups because people know how the building is going to be operating, et cetera. So I think that's one of the biggest things, is taking a look at that. I think the other thing that we're also really looking for is our partners, both from I guess our PDC teams, but also from our P3 contracts, is to bring that best practice and that look at the future for us. And we are very concerned about operations. I think, Jean-Mi alluded to it. It may take 4 years to build a building. Okay, let's say 6, 7 to plan and get it in the ground, but the cost of operating a hospital is multiples of the cost of building it. So how do we have our contractors at the table thinking value over the long term? I know that's might be a little bit controversial in this forum, but I need to say it. And as healthcare is a public good, how do we provide the best value for the taxpayers and also then for patients who come through the door? Because most people don't want to be in a hospital, but most of us at one point in time will be. So it really is just how do we bring the right minds together at the right time, provide some innovation, provide best practice, provide really the right things to kind of get the building up, get it running properly, and then keep it running properly over time.
For sure. That's great. That's great insight. I mean, especially from an owner, but also I know you've managed many hospitals and many P3s that, just kind of the emphasis on having the right people at the table, but also thinking about the long-term impacts of the decisions at the start of the project. I think that's really important. And, for all of our projects, we always have our builder and operator at the start of the project and all the way through. So definitely we agree with that. Glenn, how about you? What are your thoughts on this?
Well, kind of two thoughts. So one, I totally agree that the spirit of working together for a better outcome is key from a design build perspective. Again, I haven't met any design builders that don't want to provide the top value and top quality. So it's having those team structures to work together for a common good and being open to innovation, which may not be what's written in the specifications, I think is key, that open-minded understanding. The other thing I'd love to have contemplated in future P3s is really the risk transfer that we are currently seeing doesn't really take into effect, the laws of reality. Like I think what we need to do is really look at how do we make it more of an open pain share, gain share spirit of collaboration and cooperation for better value for providing healthcare to Canada. And I think there's a way to do it. I think we're moving every time we see an iteration of a different contract structure, it gets a little better. But I would encourage us to continue looking at that to get the most out of these team structures. That would be my comment.
That's great. Thanks a lot, Glenn. So we'll keep moving on just to keep on time here. And our next subject is more about technology, which so far I've shown I'm decent at by not muting myself. But, we've all gotten very good at using these online meeting tools and whatnot during COVID. And there was just a large shift globally accepting, virtual and online meetings. But what other technological innovations have you been seeing in healthcare facilities? On this one, Glenn, we could start with you.
Sure, thanks. So, I mean, I would start by saying Canadians are kind of funny people, being one, I can say that. We are way too modest. The innovations that we've seen here in Canada in smart hospitals, we are still at least 15 years ahead of most European countries. And it's something we should be really proud about. So we've come a long way from the time where we were focused on healthy hospitals back at the time of SARS to where we are now and really leading the world for the most part in how to automate the clinical plan for a better journey for patients. And it's something we should be a lot more proud about than we are. Even the way we design and build smart hospitals today has evolved. Like if you look at one of the hospitals we're building currently out in Newfoundland, we're leveraging the BIM and Revit models for all the traditional components. We're integrating that into virtual reality so that both the field and our office back here in Toronto, which is like 2,300 kilometers away, are able to interact in a very collaborative way for the build of that hospital. It allows us to do things like live real-time building progress, clash detection. It just gives a vehicle for us that we wouldn't have had otherwise because of the distance. We're also able to bring in the model itself into our office here, so we can have our designers and our construction coordinators come in and use the mixed reality lenses and be able to take a room, so whether it's an OR room, expand it to a point where they can have it life size and they can physically walk through that OR and do things like pre-commissioning checks. They can do mock-ups, they can do deficiency tracking all virtually from here, and everybody on site gets all of the intel and the data for tracking. It's really kind of engaged us in a different way as we're building these hospitals. Now, if you switch to kind of that's building a hospital, if you move into what's inside of a hospital, like we've made some great strides over the last 10 years as Canadian builders and hospital operators about really taking sensors, taking like real-time locating tracking systems, adding robotics, system-to-system integration that has never been seen before, automated workflows, and then artificial intelligence. And those are kind of the pieces. But if you put the pieces together and combine them, it comes down and it dramatically improves the patient journey and clinical outcomes. And that's really the purpose of technology in hospitals, is supposed to have a better outcome, have a better journey. And we've been seeing that for the last, call it 10, 12 years, and it's something we should be proud about. When we look at kind of what is the next evolution in technology in healthcare, we're really going to see it, I believe, in a extension of all of the automated processes and controls we have in the smart hospitals, and be able to extend that into the homes in the communities that they support. And I know we've done a little bit of that throughout Canada, but I'm really talking about the next level, which is connecting them with connectivity, wearables, having them with the ability for the mini robots and artificial intelligence for integrations back to the clinical plan, and have it be able to control it really for the primary goal of prevention, like stopping people from having to come into an ER, hopefully get them better, healthier lives. It's really taking all the great things that hospitals are doing now and moving it into a home. And so I think the future in healthcare and technology is really, really exciting.
That's great. Thanks, Glenn. I guess we could maybe turn to Jean-Mi for a bit more his take on this question.
Sure. Yeah. Glenn well said. We've seen a real change and focus on technology in the last few years as well, particularly with smart hospitals. And I think you're right. We don't toot our own horn enough on this, and perhaps being from the facilities management field, I'm used to that, right? Because if you don't know we exist, then sometimes that's better, right? But we've seen a greater focus on technologies that bolster our predictive maintenance and reduce in-person interventions, and so that's kind of a fancy way to say relying more on technology. A lot of what this is older technology as well, and some of it's emerging, right? So we have a lot better monitoring of variable speed drives and motors and so on. Some of them, auto lubers, more sensors, environmental and vibration sensors, and those types of things to tell us when we actually need to service the equipment, rather than just rely on a schedule, which then allows our guys, particularly during the times of a pandemic, to say, yeah, okay, we don't need to go into this critical area. We're satisfied that the equipment's going to continue to work and all those great things. The other thing you had mentioned was the BIM and Revit. That's been a huge impact for us, to sit down with a design team and go through, what an area looks like on the screen, and be able to say, yeah, I can now get to the piece of equipment that I was worried about before. I can maintain it. I can get there in an efficient way. without interrupting the hospital operations. Better to do that on a screen than to find out after we built it that we've got pipes to move and it's going to be a challenge to access. And I guess I'll leave you one cautionary example, and that is maybe around the challenges of tech, right? So as we get greater and greater offerings and efficiency, that all comes at a price. There's a propensity for things to go wrong. So in this case, in the smart hospitals, almost every system is controlled by some form of a processor with lines of code. And not only does that present a challenge in just things going wrong, but think about these complex interdependencies and integration as they grow, how difficult that is to properly commission before we get into operations. And I'm always amazed about how much attention commissioning gets on a P3 project, yet when people move in and do the things that people do, we're always surprised by the unexpected. So I'll leave it at that, but thanks, Albert.
Thanks, Jean-Mi. And what are your thoughts on this one?
Well, I think Jean-Mi's last comment is a perfect segue because as both Glenn and Jean-Mi were speaking, I'm thinking the end user is an important person as we think about the technology, because I think there's some great things out there, but we need to ensure some education and training with the end users so they on the front end, so they understand how it works and what it's going to do for them. So then when we do commission and move in, you're not getting the service call saying, well, these lights aren't coming on because no one really knows how to use them and the sensor's gone down, right? So I think there is certainly a connection to the end user here, and it goes back to, I think, to my more of my earlier comments around how do we get more people involved, from the front end, and certainly we're not going to get every clinical user in, but I think there's a couple of things that came forward that I find very interesting. One is the virtual reality. When we think about the time spent and the effort spent on mock-up rooms, if we could do that virtually, it would save a lot of time, a lot of effort, and I think it would provide our clinical teams some really good look at what these spaces are going to look like, how the flow would work, et cetera, without actually having to find a space and build a mock-up room. Now, I realize some people are more tactile than they are vision, but I think that would really, really help a lot. I think I really like the idea of all the sensors and being able to look at something without having to go into a patient room. From a safety perspective from the maintenance tech who has to go in there, but also from the patient and the nursing staff. I don't know how many times, I'm sure, Jean-Mi, you've lived this multiple times. We need to get into this room. Well, you can't. Well, we really need to get into this room. Well, the patient isn't going anywhere. You can't. So if we can do some of that work remotely, that would be absolutely incredible, because especially in maybe critical care units or those sorts of things, or frankly, in a hospital like Brampton Civic, where you are chock-a-block all the time, and maintaining something is very, very difficult. So I really think that's a great idea. And then, I'll speak for my capital development team and some of our maintenance. Again, the BIM and the rivet stuff is going to be incredibly helpful over time, because even after 30 years, when most of us are gone out of the project, someone's going to have to be taking care of that facility. Right now in Ontario, the ministry looks at a 50-year to 100-year life of a building. So even after 30 years, someone's going to need that information. And so the more we can get it off of paper and get it understandable, the better, I think, for everyone and how we operate the buildings over time. I do have to add, I'm also looking for some of the input into, the infection control side and some of the technologies that are coming around how might we be able to, the UV lights, the whatever, as long as they're safe for people, get away from the wipes and the corrosive materials that cleaning products that we're putting on these things, which just increases the number of years of life cycle and replacement that we have to do.
Great, thanks very much, Anne. we're running near our final 5 minutes, so I kind of want to turn to kind of a final question, but also tie in a question that we've received from the audience. But generally, you know, we've talked about a lot of issues that have arisen and some lessons learned, but you know, I just wanted to chat and build upon all of this and just talk about what the areas for improvement are in hospital design, construction, operations, and maintenance that we think the industry can best garner. And in part, in answering this, one of the questions are, you know, how are the Ministry of Health working with hospitals to introduce innovation, such as private rooms, greater filtration, more fresh air, so kind of design related items. But maybe we could start with you, Anne.
Sure. So the Ministry of Health, I think, is working closely with IO around a number of things. The private room issue in Ontario has become a moot point because any new facility that's built is being planned and built as private rooms. So I think that one is going to help us really a lot. There's a number of different contract forms that I think hospitals are pushing for to the Ministry of Health and to IO to say, how do we provide a little bit more flexibility in what we're trying to do? We're also trying to push a little bit of the contract form to get at, I think, Glenn, your point around how do we become a little bit more flexible around innovation? How do we pay for it? And I think that the difficult thing too is that even from the hospital owner point of view from Ontario, is there is something called local share. So the hospitals do need to come up with an amount of money on these projects, which can be in the hundreds of millions of dollars based upon the project. And when we talk about something like IT, if it's part of the construction and the systems of construction, the ministry will help support that. If it's not, if we have to bring in additional servers to do some of these things and all of that, the ministry does not support that. So sometimes you have hospitals saying, well, gee, you know, this is going to increase our local share. I don't know if we can really do this. The other area where I think the ministry is from an innovation point of view is starting to look a little bit differently and support more is on sustainability. So in our PO project here in my office, we put in geothermal. The ministry, after us pushing it a bit, approved it. We're going to try to push the envelope a little bit more and see if we can get some more sustainability in. But sometimes there is a little bit of a pushback on how, you know, what is the business case? What's the return on that portion thing? And we've got to get a little bit more flexible about that. So I think the ministry is looking at it. They're not just blinders on, and they are talking. They do have a group of hospital capital development teams that sit down with them occasionally throughout the year. We talk about lessons learned. COVID was one thing that we've taken forward. And we certainly are working with IO around contract forms and how we might do things a little bit differently.
That's great. Glenn, any kind of final thoughts from you on what the industry can best learn? You're on mute.
I had to be the one. Just one comment. So, I mean, we've talked about what have we learned through COVID and what can we do better. I mean, really, the concept of designing out waiting rooms and areas where people collect, I think we can do a better job in our future thinking about redevelopment and new development to make it more streamlined so we don't have that collection point in physical hospitals.
That's great. Thanks, Glenn. How about you, Jean-Michel? Any final thoughts?
You know, I guess just going back to Glenn's or some comments around the technology on this, I think and this touches upon both the transition design and then the operation. It's more focus on commissioning, and you know that sometimes takes more time, and perhaps we need to have. You know, I'm aware that the design builder is compressed under timelines as well, so there's a challenge there to overcome.
Yeah.
For sure. That's great. Thanks, Jean-Mi. So we're just at the end of our time now, you know, but before we close, I'd like to thank the C2P3 for having us on this panel today. and also extend my thanks to all of you, our great panelists, and sharing your great knowledge and insights on the industry, as well as our audience for joining us today. Thank you all, and have a great day.
It's been a pleasure. Thank you.
Thank you very much.
Thank you very
Thank you.
much. Have a great evening.